Hey, welcome back to my channel. I'm taking you through another day in the life as an OBGYN resident on labor and delivery. Before I head into work today, I have a virtual therapy session. I prioritize my own health, especially when I'm on a tough rotation like nights. Once I finish with that, it's time to get dressed. Since I'm on my feet for most of the night, I wear compression socks and of course some scrubs. But I'll actually be changing into different scrubs once I get to work, and I'll explain that in just a second. I am a lucky lady and Rye has already cooked dinner and dessert. If you see my last video, then you probably know that I try to eat just whenever I'm actually hungry. And I wasn't actually hungry yet, so I just packed it to go for lunch during work. And I'll grab a banana for a snack too. I always bring my laptop to work in case you have some downtime so I can work on research, answer emails, or study. Time to slip on my OR shoes, which I do clean, but also we never wear our outside shoes into our home farther than the front door. And once I grab my backpack and my snack bag, it is time to head out for another shift. One of the perks of being on night shift is that we always get to park in the garage that's right next to labor and delivery. It seems like a small thing, but when you're working over 70 hours a week, the extra 30 minutes saved every day by parking closer makes a huge difference. I typically get to work anytime between 15 and 30 minutes before my shift starts, so I can get sign out from the antepartum or APU team on their patients. We have an 18-bed APU floor. In some blocks it's totally packed, and other blocks it's a little bit more sparse. I'd say for the most of this block we've had an average of about 10 patients admitted to their service, which is pretty good, but there have been times when we get close to our 18-person cap. Since I'm towards the end of the block now, I know most of the patients pretty well that have been admitted to the APU service, so sign-outs go pretty efficiently. Before I head over for APU sign-out, I need to get changed. I kind of alluded to this earlier, but we have specific scrubs that we wear for the OR, and they come out from this fancy scrub machine. Since an obstetric emergency can happen at any time, we are always ready wearing our OR scrubs when we're on the labor and delivery floor. I'll change into them here in our locker room. Once I change and get APU sign out, it's time to head over to labor and delivery to hear more about the laboring patients. On our labor and delivery floor, we have a huge station with 2 long desks of computers, one for the nurses and one for the residents and attendings. We spend a lot of time at these computers. This is where we can monitor vitals, place orders, and document. I feel like as a medical student and pre-med, I really didn't realize how much of this job is spent documenting hospital events and courses and medical decisions. This is where we spend most of our night. We have a huge wall of monitors that show both our labor boards and our fetal monitors. The labor board lists details about our patients, including their G's and P's, their obstetric history, medical complications, labor progress, and treatments. And the other monitors show live updates on electronic fetal monitoring and how they relate to uterine tachometry and the pregnant person's vitals. So we're able to rapidly identify things like fetal distress, for which we go to the patient's room and assess potential causes and solutions. Shortly after labor sign out, I got a call from the APU regarding a patient who was feeling abdominal pain and was admitted for PPROM. I glanced at her fetal monitoring and saw some signs of fetal distress, so I immediately stopped by the supply room, grabbed a sterile speculum, a pelvic wedge, and a light, then went to her room to assess her. Patients who are PPROM'd can transition from stable to unstable really rapidly, so it was very important that I immediately evaluate her. This patient in particular was extremely important to assess quickly because her fetus was breached, or in other words, the baby's bottom was down. That means if delivery became indicated for any reason, that we would have to go to the OR for a cesarean section. Most times, and I say most times because there are exceptions to pretty much every indication, we deliver PPROM patients sometime between 34 and 37 gestational weeks, after shared decision making and depending on the complications of the pregnant person as well as the pregnancy. And this can differ also between different hospitals and providers. However, sometimes delivery needs to happen even earlier. For instance, if the patient develops intraamniotic infection, or in other words, an infection inside of the uterus, or if a cord prolapse occurs, which is an obstetric emergency. When I went to assess the patient, thankfully there was no cord prolapse, so not an emergency. However, the patient did make change from 1 centimeter dilated to 5 centimeters dilated. So in that setting, we definitely had proven to ourselves that the patient was laboring, which is why she was probably having some dips in the fetal monitoring, why we could see some contractions contractions on her tocometry and why she had some of that abdominal pain. So again, because her fetus was breached, we ended up having to move towards the OR for a cesarean section, which luckily was uncomplicated, and for her baby's gestational age really did pretty well.
Shortly after, we had a patient who was transferred from a different hospital for preeclampsia with severe features.
So whenever I get a new admission or a transfer from another hospital, the first thing I always do is to assess the patient for stability. So I'll actually go to the room, eyeball them, get their vitals, ask them a few quick questions to triage them, make sure I can know if they're stable, not stable. If the patient is stable, then I'll start by putting in some orders. That includes everything from labs and imaging to their medications to fluids and even nursing communications, like how often to get their vitals and for what parameters of those vitals that we want to be notified for. I'll also review all the records that they came with from their outside hospital, or if they have a provider that's not in our system and they have those records, I'll look through those. Then I'll take a really detailed history, and I'll also confirm anything that I've heard from either their chart review, from looking over their records from the other hospital, and all the transfer information I got from the other hospital's provider. At the hospital I work at, every single person who is admitted to labor and delivery and to the antepartum service is always consented for a possible delivery. This is going to depend on a lot of things, but for the most part, people who have uncomplicated histories and have never had a C-section, for example, get consented for a possible vaginal delivery, a possible operative vaginal delivery, as in when we use forceps or a vacuum, and then also a possible cesarean section. So I go through all of those different procedures, what they would look like, the risk of those procedures, and make sure I have enough time for those patients to ask questions. And I really actually, even though it's kind of tedious and I know not all hospitals do this, I do think that there's a lot of benefit in us doing this because it really gives patients a lot of time to ask questions if they have any questions, hopefully way before there's any indication to be delivered for those people who are in our antepartum service. And for people who are coming into labor and delivery, I like that it gives us a chance to introduce the idea that sometimes labor doesn't go as we predict, and sometimes a cesarean section does become indicated. Sometimes it becomes indicated quite urgently, and I really like that we talk to our patients up front about it and give them a lot of time to ask questions. Of course, this is something that I hope that we've talked to our patients about before in clinic as well, and answer those questions earlier. But I think that us having to talk to them on admission also just gives us another way to reinforce that we can answer patients' questions and make sure that our patients are really well informed. And then the last part of doing an APU admission for me is for patients who are viable to collect a GBS swab or a Group B strep swab, which is looking for the colonization of a really common bacteria that lives in the vagina and the rectum. But why it matters so much is if patients had an indication to need induction or to be delivered, it would also tell us the risk for the fetus being exposed to that bacteria, and also the indication for GBS prophylaxis, which is basically giving them penicillin during labor to reduce the risk of the baby becoming infected by that bacteria. And then of course we always get an ultrasound for people who are admitted as well. At the very minimal, we get a presentation scan to tell us if the fetus is either a vertex or breech or transverse, etc., because that can change our management. Then we also usually do a growth scan if they don't have an updated growth in our system.
Some nights when we aren't super busy, unlike tonight, we have time to relax in the physician's lounge. This is where we keep our snacks, have a coffee machine, and can even watch our fetal monitors. It's a cozy space and still on the labor and delivery floor, so we are available in case an emergency rolls in. We also have a triage center, which is kind of like an emergency room for pregnant patients. We're lucky enough to have nurse practitioners and midwives who work in the triage center, but if we don't have mid-level coverage, this is primarily the intern's job. Tonight, we don't have coverage, and I noticed the triage was packed with patients, so I'm trying to help my intern and assess some of these patients with her as well. Here, I'm doing testing for someone who came in with a concern for PPROM, which I talked about earlier. So we collect a vaginal sample and do a few tests. First, I'm making a wet prep using saline and potassium hydroxide. This is to look for alternative causes of abnormal discharge under a microscope, like bacterial vaginosis, a yeast infection, and trichomonas. Next, I do a nitrazine test, which is using litmus paper to check for pH, since typically the vagina is acidic and amniotic fluid is basic. And finally, I'm looking for something called ferning on a slide of a dried sample, which is often present if amniotic fluid is present.
So sometimes these tests that I was talking about are equivocal, or in other words, they don't give us a straightforward answer. So for instance, in this patient, she did have some pooling, which is like some watery discharge that accumulates in the vagina. She also did have that positive nitrazine test. As you saw on that screen before, you could see that that nitrazine paper had turned blue. However, she didn't have any ferning. And then I also did an AFI, or an amniotic fluid index, which is basically an ultrasound measurement of how much fluid there is inside of the amniotic sac. And that was also normal. So because I had this mixed picture, one of the other things that we can do at our institution is something called a Rom Plus, which is another test to see if someone is ruptured. This test looks for alpha-fetoprotein as well as insulin-like growth factor binding protein 1. This test has a sensitivity of 99% and a specificity of 91%, which is pretty dang good. So we were able to do this test, it came back negative, and we were able to discharge the patient safely home.
And just got a call from APU to go assess a wound.
I was called to her room because she was actually having some bleeding from her wound site. We can actually just grab some gauze and really just press on the area that we see bleeding. And sometimes that pressure alone is able to stop the bleeding. Other times we have to use things like silver nitrate. Silver nitrate is actually a topical medication that we can use that can chemically coagulate that area of bleeding. Other things that we can do are to throw a stitch, which essentially means that we can use suture to actually tie off the bleeding blood vessel. And then something else that we can do is use hemostatic agents, which you saw that I was carrying earlier, something called Flow Seal. I was actually able to successfully stop her bleeding, and her bleeding was stable for the rest of the night.
Now time for some teaching with our on-call overnight fellow. The rest of the night was really just spent managing normal labor and delivering babies. So here I am returning my scrubs for the day and heading back home for a good day of sleep.
Thank you guys so much for joining me again on another day in the life of an OBGYN resident. I really appreciate everyone who is watching my videos and interacting with me in the comments and liking my videos. I can't wait to see you guys in another video. I really enjoy doing these vlogs. I hope you guys do too. Please leave a comment below if there's something specific you'd like to see me do in my next video.